And hello everyone. So yes, my name's Diane Stockton, and I've been leading from Public Health Scotland side all the work that we've been doing on the education recovery, particularly the surveillance around recovery as well. I also lead the vaccine surveillance work, and these two areas of work have really come together recently as the importance of the vaccination programme on education recovery has become very clear. And that is one of the main things that I want to talk about to you today in this just quick summary. So this graph shows the current state of where we are in Scotland in terms of uptake of the COVID-19 vaccine. And it shows by age group, and the dark blue bar shows how many people have had the first dose of their vaccine, and the light blue bar shows the second dose. So at the moment you can see that we have very high coverage for everyone over 50. We have coverage of around 90% for the 40 to 49s, and then that declines as we get into the younger age group. And we've only just started to offer the vaccination to all 16 and 17-year-olds. So you can see already we've had 31% of that age group taking up the vaccine. So the figures look great, but we still have got, particularly looking at, for example, the 18 to 29-year-olds, we still have got around 27% of the population who haven't taken up the offer yet of a first dose of the vaccine. So bearing that in mind, as we then look at the next slide, we have got a situation now in Scotland where the numbers of cases are starting to rise again. So this graph shows trends of cases in Scotland over time. You can see in January when we had a big increase in cases, you can see that peak there. And then in late June, early July, we had another big peak in the numbers of cases. And since then we had a decline, but the numbers of cases have started to creep up again. And this is where, just before I was going to talk about the vaccine, what we don't see is a similar increase in cases, in deaths. So this shows the whole pandemic from when it started back in early 2020, and you can see the peaks in deaths that we saw prior to the vaccine coming in. And despite the rise in numbers of cases that we've seen recently, we've not seen that big increase in deaths due to the vaccination. So I want to talk just a little bit more about the vaccination programme and why it's so important. So I showed you that the numbers of cases were increasing again. And what this set of graphs shows, which we publish each week in Public Health Scotland, and we look at in great detail, is how many of those cases are in unvaccinated people and people that are vaccinated. And this set of graphs shows on the top unvaccinated individuals, and at the very bottom people that have had 2 doses of the vaccine, and then it shows trends over time by age in the chance of getting COVID. So you can see the main point of this graph is to show that the biggest numbers of cases that we see are in unvaccinated, and they're in unvaccinated people under the age of 40. Really important points from this graph. So one is to say that, vaccination, you can just see looking at that without anything else, that vaccination is really having a big impact on how many people are getting COVID-19, and that higher number of those unvaccinated that are getting it. The other thing to notice is that there are still cases in doubly vaccinated people, as you saw from the bottom graphs, and we do expect that. So no vaccine is 100% effective, and we will get cases in vaccinated individuals. But what it is very effective at is preventing serious illness. So you saw the deaths do not replicate anymore those peaks that we see in the cases, and that's because the vaccine is preventing serious illness. So it's very effective at preventing getting COVID, about 80% effective. So 20% of people who previously would have got COVID still will, and 80% won't. It's very, very effective at preventing serious illness. And we can see that more fully in more of the information that we publish each week. So this is probably quite a complicated table, but what it shows is over the last 4 weeks, how many people have ended up in hospital who have got a positive COVID diagnosis, And the bottom row, if we just look at that, for example, or you can see each week is very similar, and you look at the percents. So around, everyone who's had 2 doses of vaccine, around 0.004% of them were in hospital last week because of COVID, and 0.012% of people who have not been vaccinated. And if you also bear in mind that vaccinated people, most vulnerable people, have been vaccinated, then that's even a bigger stark difference when you think about that. So the key points from that table that I just showed you there, that if you're unvaccinated, you're 3 times more likely to be hospitalised compared to someone that's fully vaccinated. That's that 0.012% compared to 0.004. Also, if you're vulnerable, you're more likely to be hospitalised if you contract COVID than if you're not vulnerable. But you're far less likely than you were before if you've been vaccinated and you're vulnerable. For people who are vulnerable, when I say vulnerable, I'm talking about elderly people or people that are ill or for other reasons are more likely. But because there's still a chance you can pass COVID on even if you're vaccinated, it's really important that everyone's vigilant to symptoms, vaccinated and unvaccinated people, to avoid passing COVID-19 on to more vulnerable individuals who are more likely to therefore end up in hospital. So those are kind of the really key points at the moment around COVID-19. So the vaccine has really impacted on a severe illness. It's really impacted on deaths. It's really important to try and encourage everyone to get vaccinated to protect themselves and to protect the vulnerable. And that those are kind of the key messages from Public Health Scotland at the moment. Just the last couple of graphs to show you, because I know people will be interested in the rates of COVID-19 in children and young people. So this shows all ages, and the particular line for yourselves you'd be interested in is the 2 to 4 year olds and the 0 to 1 year olds, which is a dark blue line and a light blue line at the very bottom of the graph. So the rates of cases in the under 5s at the moment are very low, and they've stayed low over time. We are seeing increases in older teenagers and young adults at the moment. In terms of numbers of cases, again, the light blue and the darker blue bars are at the top, and for last week you can see this very small proportion of the cases that are coming from that age group. So that's a quick summary of of the data. Thanks.
Thanks, Diane. That's really helpful. Could I invite all of the panel to put their cameras on? I'll just do a short round of introductions before we go to questions. Thanks, folks. So I should have said in the introduction, very poor of me, but today we have with us, we've got Liz Levy, who works in the Early Learning and Childcare Directorate at Scottish Government, and she works in the team that's looking after the COVID-19 safety and quality of ELC. We've also got Kath Agnew, who is a Chief Inspector of ELC at the Care Inspectorate. We've got Dr. Dave Caesar, who's an Interim Deputy Chief Medical Officer. We've got Dr. Diane Stockton, who gave us a fabulous update there. She is a consultant leading on the education recovery in Public Health Scotland. And we've got one more. We've got Professor Carol Tannehill, who is the Chief Social Policy Advisor. And Carol also chairs the advisory subgroup on education and children's issues. So just to give you a bit of context on who we've got in the call with us today, thank you all for giving up the time to join us. So what we've done is we've grouped the questions into themes, as I said in the introduction. So we have a few questions around the restrictions in ELC and testing. We've got questions around the practical considerations of the day-to-day kind of running of ELC, and then we have some specific questions on parents' involvement in ELC as well. So our first question is for Carol, and I'd like to invite Amanda Wallace Davidson, if she's on the call, to ask her question. Feel free to unmute, Amanda, if you're here.
Hi, thank you.
Hi there.
So my question was, why are childcare and education working under tighter restrictions than the rest of society? Nightclubs are open, social distancing is no longer required, but my staff have to distance from each other at work, but can go drinking and dancing together on a weekend.
Okay.
Thank you.
Thanks, Amanda, and good afternoon, everyone. Just firstly from me, thank you for your interest in this session and for all that you're doing to make sure that our nurseries and early learning centres are as safe as they can be, and that children can have the experiences that they all deserve. So this is a really interesting question, and I think it's something that lots of people are wondering about, aren't they? Why are the restrictions different in different settings? So Amanda, I think there are 3 reasons that it would be important for me to set out for you. So the first one is that the advice we give and the decisions that the politicians take are all based on the balance of harms. So all the time they're looking at harms that would come from transmission and infection by the virus in the context of 3 other types of harm: wider health harms, societal harms, which include harms to education and development, crucially in the context that we're talking about today, and wider economic harms. And when we provide advice in relation to ELC and school settings, we're also balancing these harms. And at this point in time, our real priority has been the sustainable return to education. We were really, really keen that the start of this term would enable children to have a much more stable and normal return to education. So we were taking quite a precautionary approach. We know that at the start of term, you're likely to have more infections of all sorts going around the classroom and going around the settings. There's going to be increased testing, etc. And we were really keen that staff and parents and children were reassured that a lot of the precautions that were in place at the end of last term would remain in place this term to enable us to have as smooth and sustainable a start as possible. And we'll keep these under review, and we'll not keep them in place for any longer than we think they're necessary. So that's the first reason. I think the second reason is that there's an important distinction between the places that people can choose to go and the places that people need to go. And when we think particularly about those who are more clinically at risk, we're really keen that they're protected in those places where people have to go. So whether that's in shops or in schools or nurseries or workplaces. And we don't want people who are clinically at higher risk to be much more vulnerable because the people who are with them are not taking precautions that would help reduce transmission. So that's the difference. People could choose to go to a nightclub, can choose to go to a bar, but it isn't the same in a school or a nursery. And I think the third point I'd want to make is one, though, that's about equivalence. And so the reason that you don't need to wear a face covering if you're in a bar or a nightclub is because there's an exception when you're eating or drinking or you're taking exercise for which wearing a face covering would interfere. And actually that equivalence applies directly to school and nursery settings too. So if you're eating or drinking, you obviously don't need to wear a face covering in these settings either. So those would be the 3 explanations I would give you. The first one is about the balance of harms and the importance of having some stability and continuity for children and young people at this point in time, given everything they've been through and all the disruption there's been over the last year. The second one is this issue about protecting those who are more clinically at risk, particularly in settings where they can't choose whether or not they go. These are settings where there's a need for them to be. And the third one is the point that actually exceptions to wearing face coverings are significantly about when you can eat, when you can drink, and whether you're doing activities that a face covering would interfere with. So Amanda, I hope that's been helpful. If there's other issues, I can pick them up in the chat, but I'll pass back to Steph for the next question. Thanks.
Thanks, Carol. The next 2 questions are around testing and if someone is positive for COVID, and I'm getting a sense from the chat that that's something that's causing a kind of level of anxiety within the ELC sector. So the next question I think is going to yourself, Liz, first. So can I invite Janice, if we have Janice Robertson on the call, to ask her question?
Yeah, I'm kind of just looking for clarification around the guidance on a child being allowed to come into the setting if they're in a household that has tested positive with COVID. You know, our fear is obviously you're going to have these children that are not PCR tested and coming into the setting and allowing, you know, we're not going to have any control over, we know whether they're contacted COVID themselves because we're not asking for PCR tests. And I think that kind of seems to be an issue overall for a lot of people, and just looking for a bit of clarification on that.
So, but yes, they can come into the setting. So when Scotland moved beyond level 0 on the 9th of August, we removed that blanket requirement for children to self-isolate if they're a close contact. And that applies regardless of whether it's a close contact with a case in a household or in an ELC setting or elsewhere. I think the other important point, and I saw the wording of your original question, which was really helpful because it drew out another point, which was about whether parents can drop them off. If the parent has tested positive, they absolutely shouldn't be dropping the child off at nursery. Somebody else would have to bring them in to nursery. The parent would have to stay at home and have to self-isolate, and Test and Protect should be emphasising that. So our guidance for ELC settings was updated to reflect that change in policy, and that's covered in the section on staying vigilant. There's also a really helpful information sheet that was recently added to the Scottish Government website, and it explains the change in policy on self-isolation and contact tracing. It was written specifically for schools and for registered childcare settings. So we'll be adding that link to the guidance, but I've got a link now because, as I say, it's already on the website. So I'll drop it into the chat so that you can have it now. In terms of the rationale for that approach, I think it's probably best for me to hand over to our DCMO, Dave Caesar, who can explain that rationale, and also the rationale why children don't have to take very young children don't have to take a PCR test to be released from that requirement to self-isolate when they're a close contact.
Thanks, Liz, and thank you for your questions and for your sort of presence here this afternoon. It's a privilege to be here. I'd really sort of link back to some of what Carol has said in terms of the balance of harms, and especially around proportionality, I suppose, which is central to some of that balance. So, and some of the evidence that we have about transmission. So, so we know that very small people, and mostly those are very young people, have a much lower likelihood of transmitting. So not really, a really small number of transmissions are happening from small people to big people, and probably surprisingly from small people to other small people. But the vast majority of transmissions are happening in that sort of working age adult kind of group. So that's why some of that guidance seems a bit sort of quirky in terms of I need to wear a face mask here, but then I don't in another bit of my workplace. It's based on that evidence, and also the fact that we know that especially if you like preschool kids, but actually many kids and many adults rely on a lot of the cues that come from seeing people's faces. That's a really important part of their social development, their language skills, their understanding of how humans work. So again, coming back to that balance of risks and harms around that experience that kids are getting at that age. Again, that's why there seems to be sort of a sort of an incoherence of the advice, but it's trying to get the best balance of all those in all the settings that we can, whilst also managing risk when we can do that, where there isn't such an impact on some of these quite intrusive mitigations. And coming back, so I know there's quite a lot of anxiety around the testing. It's not that kids can't possibly have a PCR test, it's that it's not mandatory. So there's a gap in between those two positions, which is, if possible, it would be great to have a PCR test that was negative before they came. But we recognise that. I mean, I've had to hold my 6-year-old down to get a PCR test on more than one occasion. It's not pleasant for them or for anyone else. So if we recognise that it can be quite distressing, and that with the risk of transmission being that much lower, that's an unreasonable ask to make that mandatory, given all of the other things that they then might be excluded from. So again, all the time trying to navigate that balance of what's the best kind of whole system sort of solution for something that is a very individual thing a lot of the time. But that's kind of where we are with some of that guidance, and I can come on up, try and answer some of the PCR LFT stuff later if that's helpful, if there's time.
Thanks both. I'm going to very briefly pull in some points from the chat because I'm conscious people watching the recording won't have access to the chat. So there was a question around can a child or a young person with a high temperature, they were unable to attend an ELC setting for 48 hours even with a negative PCR test, and there's a response to say that children with a temperature should not be attending ELC settings until they feel better. So I suppose the last point on that was there used to be a 48-hour exclusion. Is that still in place even if the child or staff member has a negative PCR test? I don't know if Diane or anyone else in the panel wants to come in on that point. Does the 48 hours still stand even with a negative PCR?
Stephanie, I've emailed colleagues in Public Health Scotland to try and get clarity on that point because I'm not clear. I'm not clear on that. I don't know if anyone else on the panel is.
No, that's great. That's fine. We can feed that in when we've got that information. Okay, the next question we've got is for Liz, and that question is, if children are not to isolate or book a PCR test after being in close contact with someone with COVID, how do we manage to care for the children / meet the ratios when staff are expected to? So I know that was mentioned in the chat as well. So how do we accommodate staffing levels?
Yeah, we absolutely recognise that even if children don't have to self-isolate as close contacts, the requirement for staff to have a negative PCR test before they can come back to the setting is going to have an impact on capacity in settings. And Carol's also mentioned that kind of balance of harms. We call it a 4 harms assessment that we do of the risk mitigations in childcare settings. And that captures a range of mitigations, including the impact on capacity and the ability to provide children with ELC that meets their needs and the needs of their families. And in that 4 harms assessment, we've logged this, absolutely. We've highlighted that the requirement for staff to self-isolate will create a pressure on capacity, that settings may still need to close rooms, and that's very likely going to mean some continued disruption to ELC. That does seem inevitable, and in fact we've heard about it already this week in certainly one setting. I understand, and perhaps others on the panel can confirm, that PCR tests, most of them are returned within 24 hours. So that disruption should be fairly short-lived. I see Dave nodding, that's great. It should certainly be an improvement on the previous policy where all close contacts would automatically have to self-isolate for 10 days. But the risk is that change in policy creates an expectation among parents that there'll be no more disruption in ELC settings. We're very aware of that. That's not going to be the case. There will be disruption. And if we need to do more to manage that expectation, we can do that through Parent Club. And we'll come on if we've got time to talk about what more we can do to communicate with parents. It's worth saying while I'm here that we regularly monitor staff absences in the sector that are due to COVID to help us with that 4 harms assessment that I mentioned. And our main source of data is data that we get from Care Inspectorate on staff self-isolation and the weekly staff absence survey. Unfortunately, response rates are pretty low at the moment. Would really like to improve that. We know it's an additional ask and we know how busy everyone is, but if as many settings as possible can respond to that, that'll help us to monitor the impact on capacity and think about whether that needs to be reflected in our 4 harms assessment. So I don't know if Kath wants to say anything about managing the ratios while staff self-isolating, just to perhaps underline that there would still be an expectation there.
No, I absolutely agree with what you've said. I mean, someone who put in the chat had said, how do we do it safely? And the way to do it safely is to make sure you've appropriately skilled staff with the numbers that you require. Because while the adult-child ratio, is there, it may be that you have to actually reduce that depending on the needs of the individual child. So it's important to keep that balance. And I do agree, it may be, and we're monitoring that as well. When you notify us of cases where there are issues, we actually share that with Public Health and share information with Scottish Government. And I would agree with Liz, if people could, I know it's an additional ask, submit the weekly staffing it does give more information in order to fulfil these future decisions. But it really is, it's a difficult time for everybody, and it is going to be a challenge. But there is also, remember, we're at the start of the new term, and I know in the chat said as well that private sector have been open throughout the summer, but there are some settings coming back with brand new children, and it is really important that you have appropriate staffing to meet the needs of these children as we move forward.
Thanks both. The chat is fairly busy, as you can maybe tell, so I'll let you catch up with that. There are a few points in there about what if staff don't want to be vaccinated, so they don't plan on getting the vaccination. A lot of staff in the ELC sector are not double jabbed yet. So if any of the panel want to catch up on that, feel free to answer in the chat pane, or you can raise your hand if you're on the panel and you want to come in on any of the points in the chat as well. I'm just conscious we've got quite a lot of questions, so I don't want to add any more in at this point. The next question is from Elizabeth Mackay, if we have her on the call.
Hello there, yes. Hi, part of my question's actually been answered in the last one, but really I was concerned because I took part last year in the antibody survey of education staff, and I've had a quick look at the initial findings of the survey, and I noticed that the staff group with the highest percentage of antibodies over the period, so in other words, the highest number of staff who became infected over the school year was early years staff. So I was concerned about where is the data and the evidence which supports the fact that children under 5 are able to return to nursery if they have no symptoms when there's a positive case, even in their own household, because then surely that risk is going to continue throughout that infectious period if there's a member, a parent or a household member who have tested positive.
Diane, I think that question was originally aimed for you, but if any of the panel want to come in, that's fine.
No, I'm happy to come in on that. Thanks, Elizabeth. So I think there's a few things to note. So probably the first thing is that that the antibody survey didn't give us enough details on the aspect of didn't give us details on how the COVID was contracted. So we need to do a different study to look at that. And one thing I think to note is that you might be aware of is that we've been working with SSC to find ways to identify the early learning and childcare workforce within our Public Health Scotland data, so that we can look at that risk in a lot more detail. And we are going to, you might be aware of the teacher case control study, which we're going to do with the ELC workforce as soon as we've finalised all the governance and permissions to do that piece of work. So that's worth knowing. The evidence that's been used to make the decisions that it's already been partly covered previously. It's worth also knowing that both internationally and in England and with our own data in Scotland, a lot of work's now been done looking at transmission risk. And one of the pieces of work that we've done was looking at transmission risk between different groups of people. So, for example, adult to adult, symptomatic adult to another adult, symptomatic adult to a child to a child, a symptomatic child, and different age groups of children. And that showed that children under 5 who with no symptoms have got a very low risk of transmitting COVID-19. So that is part of the evidence that has been used, and that data comes from all the test and protect data. So when cases are identified and the contacts are identified. So we've got a lot of rich information on that we use to inform those decisions. So I hope that helps with that understanding.
Thanks, Diane. Before we move on to the next sort of section of questions around the practical considerations in ELC, I just want to reassure the chat pane that although it is going quite quickly, we will download and save the chat pane so that any of the kind of crucial points and questions that are being made in there, we will give them to the panel afterwards. And if there's any other advice or links that we can send, we will do that via email to the people that signed up for the call. So please be assured that we are taking everything on board there. So the next question moves on to the area of the importance of hygiene. If we have Carol Blair on the call, would you like to come in and ask your question?
Hygiene. Should there still be further safety measures in place for snack and lunch provision within ELC, or can we revert to children serving themselves, etc.?
Liz, I think that one was for you.
I'm just going to give you a very quick answer and then pass over to Kath and perhaps Diane if she wants to add anything. So there's a section on the provision of meals and snacks in the guidance, and it says staff should follow the usual hygiene practices when preparing or serving food or assisting children with packed lunches. On that specific question about children serving themselves, I'm going to pass to Kath, who can perhaps explain what the care inspectorate would consider to be good practice. And then if Diane has any other advice in terms of infection prevention and control, please feel free to
add. Liz, we would always follow advice in IPC from any professionals, but obviously the benefits of children serving themselves at snack time and meal times is something that we would absolutely promote, and it is within the resources that we've published. But unless there was a public health reason not to do so, then we would go with children being as independent as possible. Don't know, Diane, if there's anything else from that public health that you would want to add to that.
Probably not, Kath. No, I think that will be the same. David, I don't know whether you want to add. Yeah.
Great, thank you.
No, I mean, I guess just on that point, so there's lots of things that are shared in these settings, which, if you like, are inanimate, and then there's a lot of shared space with animate people, people and other things. And our understanding of how this virus transmits has evolved over the last 18 months. As Diane was mentioning, our understanding of the routes of transmission has evolved and shifted a little bit more towards the, if you like, the respiratory mechanisms rather than just the droplet and hygiene mechanisms. Now, those are still really important for this infection as well as for lots of other infections. So hygiene measures are still really crucial just generally, and actually one of the things that we hope will be a legacy of COVID will be actually just that we understand better how infections transmit in lots of different settings, and that we maintain some of these hygiene measures that have undoubtedly reduced not just COVID to a certain extent, but also many other respiratory diseases and shared diseases of childhood and of adulthood. But as we mentioned before, it's a balance of how intrusive these measures are versus the sort of protective effects of them as well. So it's not to say that there's nothing in maintaining some of those hygiene measures, not suggesting about that specific point about self-serving, etc. But just to sort of retain some of that vigilance around ensuring that we're as hygienic as possible, whilst understanding that these are pragmatic, often practical decisions that have to be made on the ground in uncontrolled environments like nurseries.
Thanks all. There are a couple of questions here that I'm going to ask on behalf of the people that submitted them. So the first one for yourself, Liz, is can we now plan for playrooms and spaces without keeping the children in bubbles?
So what I'll say is that keeping children in bubbles or cohorts is still a good idea. That helps settings to have as much consistency as possible in the staff who are working with children and working with each other. So that if there's a positive case, you can limit the number of staff who need to self-isolate while they wait for the results of that PCR test. So we talked about how that impacts on capacity already. So it would make good sense in terms of that, managing the impact of self-isolation. However, from level 3, the only restriction on group size is your registration capacity. So from level 0 and below, beyond level 0, you can return to pre-COVID arrangements if that's what you want to do. The guidance makes clear that group sizes do have to be reflected in your risk assessment, so you should consider the impact on transmission risk and mitigations that you might want to put in place around that, and the kind of impact on isolation and staff absences. But yes, you can return to whatever group size works for you, provided it's within your registration capacity. It's also worth highlighting that we updated the guidance just last week to say that in protection level 0 and below, There's no requirement to separate groups of any size when they're outdoors. The risk of transmission is much lower when children are outside, so we're encouraging settings to make as much use as possible of outdoor space. You already know that it's good for children's development, and now we're seeing it's also effective in terms of a COVID risk mitigation. So groups can be mixed when they're outdoors if it makes it easier for you to maximise the time that children are spending in the fresh air.
Thanks, Liz. There are a few points in the chat that I'm just going to draw to the panel's attention. So there's a question around toothbrushing, if anybody would like to reply to that in the chat. There's also a question about baking, so quite specific examples of hygiene-related matters. And there's just one final point there, just to have possibly a yes or no. So does that mean children can self-serve snack whilst being hygienic as possible? So if we could just get a kind of final answer on that in the chat as well, that would be great.
So there's nothing in the guidance that would preclude that. That would be my position unless Kath wants to.
Perfect. Thank you so much for that clarification. And Kath is in agreement. Fab. Thank you. So the next question is, will the local authority supply CO2 detectors to partnership nurseries? And again, that's for yourself, Liz.
Yes, that's an easy one. The intention is that local authorities will procure and provide CO2 monitors for all daycare of children's services in their area, and that will include partnership nurseries or funded nurseries, but it will also include other non-funded providers too, so it goes way beyond that. And we know that some local authorities are already bulk ordering monitors in anticipation of sharing them. We're leaving it for local authorities to decide if they provide each setting with their own monitor or whether they give them access to a mobile monitor that they can borrow on rotation. That's completely up to them, whatever works. We've asked local authorities to provide an email address that providers can use to request a monitor, and we provided contact details for 16 local authorities in a provider notice that was issued on Tuesday via the Care Inspectorate, where we're still waiting to hear from the other 16 local authorities, but we've been chasing and we're getting more contact details in. So hopefully we'll issue an update early next week. I know the question came from a manager in Glasgow, and I do have the contact details now for Glasgow City Council. We got that yesterday, so I'll drop that into the chat so that you can make contact. But I think that Glasgow has already reached out to its funded providers just this week.
That's great. Thanks, Liz. Just to pick up the point about temperatures, there has been an answer in the chat just for those that are watching the recording. So the Public Health Scotland view is that the 48-hour exclusion should still apply, as the child could still have another infectious disease. So the 48-hour exclusion if the child or practitioner has a high temperature still applies. The next question is for yourself, Dave, and a popular one, it was asked yesterday as well. When can we stop wearing masks in nursery? And when can we operate under normal conditions again? The pinnacle question, I think.
Yeah, and I'll give my same frustrating. If I knew that, I wouldn't be sitting here. But as Diane mentioned, you know, the way that COVID is oscillating in terms of case numbers is one of the sort of, I suppose, great uncertainties that we're still dealing with. So the overall aim is that we are trying to ensure that we get back to as normal as we can whilst maintaining what is a tolerable degree of safety measures, baseline measures that don't limit things too much, that allow kids to be looked after and educated, that allow businesses to function, that allow people to get back to something as close to as normal as possible, without allowing case numbers to become so extreme to allow that might translate to long COVID, that might translate to hospitalizations, that might translate to deaths, that might overwhelm our NHS. And these are all fluid equations that are changing this week on a day-by-day basis. And so it's likely that we will be sticking with some degree of tolerable mitigations, in which I would include face coverings and enhanced hygiene for a reasonably long time, if not the foreseeable future. Certainly I can't see those being phased out in the next few weeks, for example. So there are some things there that as has been mentioned, while things might not be absolutely set in stone and mandatory, we would be really encouraging people to continue doing around just trying to make sure that we are allowing each other to be as protected as possible whilst allowing life to go on to a certain extent. That's really the balance we're going to strike. But I can't see that these measures will that are, if you like, minimally invasive are going to go very soon, I'm afraid.
Dave, if I could just pick up with you a point in the chat, and if any of the other panel members want to come in on this, there's a little bit of confusion. So there's been some messages around not wearing masks with children, but wearing them when you're within 2 meters of another adult. So is there a different scenario? If you're with children, you don't have to wear a mask. If you're with adults, you do. Is that correct?
Yeah, that's exactly it. So in areas of your workplace or actually any public place where where it feels relatively crowded and the distance that we're working to is if you are within, if you are obviously within 2 meters of other people and you're going to be within that sort of space for longer than a fleeting moment, so you're not just kind of passing someone in a doorway, then we would recommend and encourage you to wear face coverings in that instance. It comes back to when you're essentially providing care and a service for the kids under in your care, looking after them, and with the different risks of transmission in that particular setting, that face coverings are felt to be more detrimental to your ability to provide that service and to provide that care, but also the flip side of that is that there is much less risk in that particular scenario, given all that we've talked about before. So that's where we're at with that just now. So and of course these things are dynamic. No one stays in one place largely for any particular point in time. So there's a bit of good judgment in this and common sense that we ask of people, and I'm sure Kath and her colleagues aren't going to be coming around with the measuring tape in terms of how far people are away from each other in their staff room or however it is, but there are easy mitigations around that, so around scheduling, around being outside, around encouraging ventilation, and all these other things all reduce the risks of these particular moments and activities, and so we're going to need to be creative as we get into the winter, of course, but that's what we're going to try and encourage.
Thanks, Dave. Unfortunately, folks, we have run out of time. I do appreciate if people need to go. That's absolutely fine. Thank you so much for joining us. We are going to close with a kind of short input from Liz around how to kind of communicate with parents about the recent guidance changes. Questions that we didn't manage to answer in the time frame, and any questions in the chat, we will get the answers or links or something sent out to you, so you will still get an input on them. So I'll pass over to Liz for some closing comments.
Yeah, there was one question about guidance for parents coming back to the setting, and I think it's an important point to address, because we know that engagement with parents is such an important part of the ELC experience, and it's something that you do really well. And children are missing it, parents are missing it, and settings are missing it. So you'll know that in level 0 and below, parents can come back in a managed way where it's necessary to support children. And we talk about the example around transitions to a new setting. Our schools guidance also takes a really similar approach. We've got some conditions around those visits to make sure that they happen safely. We know that you're keen to welcome back parents in a wider range of circumstances with less restrictions. So that is something that we're going to be looking at. We're committed to try and keep the guidance stable until the end of September, by which time all adults would have been offered at least 2 doses, both doses of the vaccine, and 2 weeks would have passed. So by which time risks should be even lower and confidence among staff should be higher. That would be the time to start thinking about easing the restrictions. So we'll be commissioning some advice from the advisory subgroup in the next couple of weeks about what we could say about visits by parents, but we absolutely recognise that it's important for you to try and get parents back into the settings. We wanted to, if you've got time, just to drop some thoughts into the chat. We'd like some feedback on how we can communicate better with parents about these changes that, you know, that it's difficult changes to understand and understand the rationale behind some of those. We've touched on, for example, the importance of parents knowing about the self-isolation rule, that they can't bring children into settings if they need to self-isolate and if they're symptomatic. If there's anything else, any other messages that we can get out to parents, we can use the Parent Club website, we can use their social media channel. So if there's any challenges you're experiencing around communicating with parents about any of this, please let us know in the chat or later on, feedback to us, and we can think about how we can address that. Thank you.
Thanks, Liz. Just to thank all of the panel for your input today. It's been really appreciated. You can see that in the chat, and hopefully we can have the chance to do this again if the guidance is updated. And just to thank all of our participants as well for giving up your time to come along and engage so enthusiastically. And that is us for this evening, folks. So have a lovely evening, and I'm sure we'll speak to you again soon. Thank you.